Welcome to Evening Rounds. My name is Dr. Jessica Long, and I'm a pediatric and adolescent gynecologist in the minimally invasive gynecology division of the obstetrics and gynecology department at the University of Chicago. I specialize in gynecologic needs of, or providing care for gynecologic needs of pediatric and adolescent patients as well as young adults. In today's session, we'll focus on vaginitis and sexually transmitted infections, where we'll be covering the symptoms, diagnostic screening, and management of these infections. This session is a part of our continuing education series for OBGYN nurses and medical assistants. We will have a short period of time at the end for questions. So kind of write any questions down that you might think of as we move through the presentation. Okay, we just want to kind of center ourselves in our vision, and basically together we can elevate the human experience with knowledge and healthcare. Our mission is to continue to have values that commit to excellence, embrace curiosity so that we can grow together like we're doing now, embody equity, and make a difference in people's lives and take ownership over the care that we provide. I don't have any disclosures at this time. So today's agenda. So our plan is to review the most relevant or prevalent, STIs, to review causes of vaginitis or like inflammation of the vagina, explore the screening guidelines and management of common STIs and vaginitis, and to discuss follow-up recommendations for common sexually transmitted infections and vaginitis. So just some background. In 2023, 2.4 million cases of chlamydia, gonorrhea, and syphilis were found. 48.2% of those that were infected were in the population that I love to take care of, so those between the ages of 15 to 24 years old. And they only make up about 25% of the sexually active population. So it's really important for us, one, to focus on all people, but this is sort of a special population when we're thinking of the people who are calling in and symptoms that they have, what testing we might provide them with. There are disparities, and those disparities are increased with increased prevalence under those who are sexual, so identify as non-straight and racial minorities. And so that's another kind of thing to keep in mind when thinking about testing. Why are there disparities? So oftentimes people are not necessarily getting screened regularly. They may not have access to screening or testing for sexually transmitted infections. They may have a lack of knowledge or education about how to avoid sexually transmitted infections, or a lack of resources to access the education and or the testing. Some folks have multiple sex partners, as well as asymptomatic partners. Many male or penis-bearing partners don't oftentimes have symptoms and are then giving those infections to, vagina or those identify as women. For those that identify or are adolescents and young adults, there can be concerns related to trust and confidentiality, or related to their medical providers, either giving that information if they are positive to their parents. For young people, brain development is a big key. They're risk takers and they don't think that they're going to get infected, as well as cervical anatomy in young people. So anyone like sort of less than 25, there's the cells of the cervix are columnar in adolescents, and so therefore they're more susceptible to infection. And so some strategies that we can implement to improve outcomes that you might see some of us do is recognizing the presentation first and foremost. So a lot of folks who have sexually transmitted infections are being affected by some inflammation or infection of the vagina, so vaginitis, often have vaginal discharge. They can complain of vaginal odor. Some of the odors people talk about are fishy odor, a yeast or a sour smelling odor. Something can be musty. Oftentimes they have a regular menstrual cycle, so either bleeding between periods, bleeding after intercourse, or postcoital bleeding, or prolonged bleeding. Some folks complain of vulvar irritation, itching, burning. And this can definitely be a sign of primary herpes simplex virus, or HSV. And for them, they can oftentimes also present with viral symptoms. So things like feeling fatigued or fever or having body aches, as well as having like ulcerative lesions in their genitals. Some folks have pelvic pain, and like I said before, some people can have no symptoms at all. So here we're going to kind of go into each. I just kind of put it up there. You can take it as you will. Maybe I should have just done one at a time, but here we are. So for screening guidelines for gonorrhea and chlamydia, it's anyone sexually active less than 25 years old. The recommendation is for yearly testing. Oftentimes this changes if somebody has multiple or anonymous partners, you can offer them, standing orders in the lab every 3 to 6 months for testing so that they're having, getting treated for any infections they may have more often and not kind of missing it and allowing it to cause inflammation or any scarring in the pelvis. If somebody does have a positive test for gonorrhea and chlamydia, we're going to be testing for reinfection. So we're not testing to see if the treatment worked. We're just making sure, are they still having sex with the same partners? Are they still having the sex within the same community of partners? Did those people get treated or not? And so we're wanting to make sure they didn't get reinfected. And that's usually done 3 months after treatment. For herpes simplex virus, for symptomatic individuals, we really want to see them within 72 hours. So if somebody calls in and says, I have this ulcer, it's painful, really they should be coming in and we should be swabbing those lesions pretty soon after they develop symptoms, or if they're having burning, itching, tingling. The other thing is that we generally don't recommend serologic testing for just the general population, just because nowadays HSV1, which is the virus that typically in the past was relegated to the mouth, and HSV2 to the genitals, it can go cross because people are having sex with their mouth and their genitals, and so serologic testing doesn't really help us understand whether they are going to be at risk for having vulvar lesions. And it doesn't really influence how we treat them, moving forward. But there are special populations where we do serology. So those with recurrent or atypical symptoms. So they keep having this burning. We do the testing with like MVP swabs to see if they have like BV yeast or anything else. It's always negative. Then using HSV test serologic or blood testing may actually be helpful. Those with multiple partners with HSV, and that's kind of thinking about whether their partners need suppressive therapy or not. People with HIV, so somebody who's immunocompromised, somebody with multiple partners with HIV, and those just immunocompromised at baseline. For trichomonas, oftentimes people are asymptomatic. It can occur in high prevalence communities, so you're going to want to be doing testing oftentimes in communities where there is a lot of trichomonas, but oftentimes I just do it regularly with other testing. People with multiple partners, those that participate in transactional sex or have drug misuse history, history of sexually transmitted infection in the past. Oftentimes, if people are positive for chlamydia and gonorrhea, then you haven't tested for trich, probably should incorporate that or recommend that they incorporate that. And then I think that for everything other than HSV, as I just mentioned, really we should just be doing universal testing because you catch more, you can treat more, and help people be infection free. And then the last one is Mycoplasma genitalium. We've all kind of heard about this. It's caused a lot of headaches in many ways, but routine screening is not recommended. However, there are special populations where we should incorporate testing, and those are folks who come with urethritis, so inflammation of the urethra. So maybe they're having burning with urination. We did a urinalysis, it's negative, maybe incorporating that. That's also in kind of like those assigned male at birth who have penises that we may take care of as well in some of our gender affirming care clinics. Cervicitis, so inflammation of the cervix, those that have pelvic pain and discharge, or we're concerned for PID or pelvic inflammatory disease, and those with persistent symptoms despite treatment. So they're still having discharge, they're still having irritation, they're still having pelvic pain, then we can incorporate Mycoplasma genitalium since it can be a cause of PID and rule it out. As well as if their partners have had Mycoplasma genitalium, then we should likely test and treat. So now more for the vaginitis piece, we have two kind of things that can present that we see oftentimes in the clinic, which is bacterial vaginosis and yeast. They most often show up with abnormal vaginal discharge, For bacterial vaginosis, oftentimes people are complaining of a thin, watery, grayish white discharge and a fishy odor. Whereas with yeast, oftentimes complaining about white, clumpy discharge, sour dough bread smell to their discharge. Other complaints that can be common to both are itching, burning, some pain with intercourse, vulvar erythema or redness of the vulva. And then BV specific, BV can cause pelvic pain and it can cause PID. So, kind of keeping that in mind if we're kind of people keep coming and they're complaining about things to incorporate that. Some testing options, urine is kind of just as good as swabs, is just as good as an eye swab or they self swab. So for urine, we're doing that for chlamydia, gonorrhea, trichomonas, and mycoplasma. It should be a first catch. So it's important that they haven't urinated 30 minutes prior. So oftentimes catching them right when they get in there, haven't peed in a while. We have swabs for gonorrhea, chlamydia, trichomonas, mycoplasma digitalium, yeast, and BV. This can be via self swab, where they're putting the swab in their own vagina, as well as endocervical and vaginal swab that's provider performed. And all of those kind of find the same results and are just as effective. There are special sites that we look at. So oropharyngeal, so the back of the mouth, and rectal. These are sort of reserved for special populations for testing. And you probably don't often see us do this testing in clinic unless we're taking care of the special populations or these special circumstances. So those who have unprotected intercourse in general or contact with gonorrhea, chlamydia, positive sex partners, that's what NG and CT stand for. If they identify as gay, bisexual, or transgender women, so assigned male at birth, anyone who's a sex worker or contact with sex workers, and if somebody comes in and has pharyngeal rectal symptoms, so say for instance you did urine testing, you've done swabs of the vagina, but they're still kind of complaining of a sore throat or swollen glands or like itchy rectum, testing in those areas may be performed. For treatment for chlamydia, preferred is doxycycline, 100 milligrams twice daily, 7 days. Oftentimes, it can cause irritation of the stomach as well as the esophagus. So that's what gastritis and esophagitis are. So I oftentimes will prescribe Pepcid concurrently with doxycycline. So they can take Pepcid, I think it's 20 milligrams twice daily for 7 days as well to decrease that feeling. If somebody's pregnant or they just can't tolerate doxycycline, then you can use azithromycin 1 gram once. And for all of these, for chlamydia, you can do expedited partner therapy. So oftentimes that's either doubling the dose. That's kind of confusing for a lot of people. So usually I just give a refill and then have them take the refill out immediately and write a note in the pharmacy section that they're going to treat their partner if they agree to do that. The next is for gonorrhea. That's going to be, we're giving IM ceftriaxone. If they weigh less than 150 kilograms, they're going to get 500 milligrams. If their BMI, I should say, weighs greater than or equal to 150 kilograms, they're going to get 1 gram. Alternative treatments, really, the CDC doesn't recommend alternatives. And if we need an alternative, then we should be connecting with ID for input or infectious disease. And then if they do have pharyngeal, so mouth or throat gonorrhea, they should have a test of cure within 14 days. So that's the only population where we're doing not necessarily tests of reinfection, but we're really looking like, did we treat the infection and making sure it's gone. Next is trichomonas. And also we can't do uh, expedited partner therapy with gonorrhea. People's partners should be going to get treated at their own doctors or like an urgent care center or something like that. Next is trichomonas. Preferred treatment for this is metronidazole, 500 milligrams orally twice daily for 7 days. An alternative is tinidazole, 2 grams orally in a single dose. With either of these, we really should be recommending people avoid alcohol for 24 hours, aphylaxis of flagyl, so for the 7 days and then 24 hours more. And then for tinidazole, it's for the 7 days and then 72 hours after the last dose, because otherwise they'll feel really crummy and nobody likes that. Um, So some ways of improving treatment success is we should be counseling our patients to avoid sexual intercourse for 7 days of while they're being treated and making sure that their partners are being treated before they have intercourse and potentially even testing, and then getting back to sexual activity. But as we just talked about, testing typically isn't happening for about 12 weeks, for most things. Testing and treatment for any partners really should be within the previous 60 days since diagnosis. So we really want to try to cast a wide net and decrease the disease burden, in that population and be providing expedited partner therapy for things like chlamydia and trichomonas as we can. Um, I went backwards in time. Apologies. I'm gonna like get it together. Okay. Next up is treating herpes simplex virus. There's many different options. I kind of put what is preferred. I won't read them all, but usually we're doing the valacyclovir or Valtrex 1 gram PO twice daily for 7 to 10 days, and 7 to 10 days really just depends on people's how bad their symptoms are. So if they have really terrible symptoms, their vulvas like very ulcerated and they're really in a lot of pain, then I would say 10 days is probably what they need. Otherwise, really, for this population, should be thinking about some supportive care measures that we can counsel them to use. So things like sitz baths, so just sitting in warm water. They don't need to put anything extra in there. Using a pericare bottle while they pee. So, similar to our patients who've just had a baby and had the vagina and had repairs done, we're kind of like telling them to put water to decrease the acidity of and the burning of the urine. They can use a cup if they're at home, like a big cup that has like lots of water and it start peeing and pour. Do that with a lot of the young kids who have other vaginitis reasons. Using ibuprofen and Tylenol, telling them that can take, alternating one every 3 hours. So 600 of ibuprofen followed by 500 of Tylenol or 325 to help with decreasing inflammation and pain that they might have. And then we can also prescribe lidocaine ointment, and or tell them to apply Vaseline to, decrease friction. Lidocaine ointment better than cream. Ointments don't burn because they don't have any alcohol in them. So that's what we should be leaning into. For risk of recurrence after the first episode, because people ask these questions sometimes, like, when am I going to get it again? 40% have 6 recurrences in the next year, 20% about 10 recurrences. There's 2 ways of managing post, like initial outbreak therapy. So you could do episodic treatment where they have like a standing order in the pharmacy and they start having tingling or they have their lesion and they just go pick it up and they treat. They can also do suppressive therapy where they take a pill every day. And this is usually based on if they're having frequent and severe recurrences or if they have a partner that does not have HSV. So that's a kind of another situation where you may test to be like, oh, you don't have any positive for 1 or 2, your partner does. Maybe you should suppress so that your partner doesn't get infected. And then otherwise, like all things, we should be recommending using condoms unless they're trying to get pregnant. For yeast infection, there's, using oral regimens are one option. Some people prefer using a regimen for treating in the vagina with like a cream-based treatment. So fluconazole, 150 milligrams is often what we use. It can be used once, but it can be given every 3 days. So I oftentimes will prescribe people 2 tabs. I'll say take 150 now in 3 days if you're still symptomatic, and we know that you had a concrete culture that showed yeast, then you can take it again in 3 days, and hopefully your symptoms will get better. Also, there's vaginal suppositories. I'm not going to go into like, there's so many options. Clotrimazole, miconazole, you kind of can choose what's covered by their insurance and on formulary, or just encourage them to buy it over the counter. Some people have external symptoms, so they'll have like kind of irritation of their vulva, but also like, the yeast inflammation within the vagina. And so clotrimazole plus betamethasone cream, which as a trade name is called Lotrazone. But these can be either prescribed in their separate components and told to use together externally or as one component. And then some folks do get recurrent yeast infections, and that's defined as if they have 3 plus culture-proven infections within a year. Oftentimes you're wanting to rule out if there's a resistant strain. Really nice for us right now are multi-vaginal panels actually test for some of those resistant strains that respond better to things like boric acid or need to go to like ID for some special higher level antifungal. And so, we should be thinking about that's why we want to test because we want to make sure that their irritation is actually like yeast. And they give us a story of yeast and they've had yeast before, then fine. But oftentimes we want to be testing just so we can, if they do have recurrent yeast infection, we want to think about why. Do they have diabetes? Do they have HIV? Do they have something else that's making, or are they taking like chronic birth control pills, which sometimes can cause vaginitis? And so then we can talk through some like more long-term management strategies. For a bacterial vaginosis, preferred regimen similar to trichomonas is metronidazole 500 milligrams twice daily for 7 days. They can also use one applicator full of the following medicines in their vagina. So metronidazole, 0.75% gel for 5 days, or clindamycin, 2% cream for 7 days. Oftentimes we're going to these like gels and creams like later on when they've like failed treatment by mouth, and it's part of the recurrent BV workup pathway. But they can also have these kind of from the outset if they like. Excuse me, for recurrent BV, again, this is 3 infections within the year. There is a new study that came out. And again, I think harping on the fact that we really want to make sure they're not just like, my discharge is fishy odor, like we want to make sure, oh, you do have BV, you've had it 3 times. Let's talk about some ways to kind of make it go away and be more consistently gone. There was a recent study that was a randomized controlled trial that showed that if you treat the partner as well, especially if they have a male penis-bearing partner, then oftentimes they have a longer latency of no BV symptoms. So for partner therapy, we're not going to be prescribing that, but we can give counseling about like this is what the regimen would be. They should go to their primary doctor to get this regimen. It's metronidazole 400 milligrams. I don't really know if that actually exists. Um, but in the study, that's what it was. So I'm sure if they did 500 milligrams, it'd likely be fine, but twice daily for 7 days, and then applying the metronidazole gel to the shaft of the penis and under foreskin if they still have their foreskin for 7 days as well. And that increases the latency of no BV symptoms for the female partner. Some other prevention strategies for current BV or yeast, or just BV and yeast in general, is vulvar hygiene practices. So encouraging our patients to wear cotton underwear, to put water only on the vulva or gentle soaps as needed, so things like Dove, stuff that doesn't have scents in it. Using condoms regularly with intercourse when not trying to achieve pregnancy. Semen in the vagina. Semen is basic. Vagina is acidic. So you're putting something basic into the vagina, it changes the pH. So less of that is better. Flushing genital parts following sex. So just like have sex, take a shower, or wash the vulva, flush the vulva with some warm water. Helps to get the other bacteria from the partner off of the vulva and decrease the risk of imbalances in the pH. Avoid douching, so we don't need to put anything special. The vagina cleans itself, so no baking soda, no apple cider vinegar, none of that needs to go up there. Sitz baths for mild irritation, so again, sitting in warm water. Avoiding special vulvar products, so Sea Breeze, like Vagisil, any of those, just put them in the trash can. And then plain toilet paper, that's supposed to say, or water wipes, kind of just not do, again, no perfumes. And then test before treating as much as we can is really helpful because we want to know we're treating the right thing. And then, like I said, ruling out immunocompromise. So ruling out diabetes. So many people have pre-diabetes, ruling out HIV as a cause of making people having recurrent infections, especially if we feel like everything else is negative. So, we wanted to touch on some team approach to care. So I think some things that can happen, in the clinic as far as like the medical assistant, if they come in and they didn't have a complaint already in the complaint in the system in Epic and they say, oh, they're having discharge, maybe looking when were they last tested for sexually transmitted infections, collecting urine samples before they're like either peeing at will or in the room to kind of help that process move forward as much as you're able to, as we move forward with this education series, providing education, potentially demonstrating how to use a self-swab collection, especially if somebody's waiting while like a provider's in another room and this person says, oh, I'm having discharge, it's white, clumpy, it smells like, fishy, then they could start to collect those things while they're waiting and then kind of improve the process of turnover and them getting and being satisfied with the care we provide. And then rendering treatment of gonorrhea. So I know that there are like body area zones for the nursing and medical assistants. But if we know somebody's already positive, kind of moving forward with getting that going so that we can again have less delay. And then role of the nurses. I know that you all field so many calls, gathering information about symptoms, determining is there a need for an office visit or can we provide empiric treatment? Like this person had a BV positive test 3 times already this year. Likely they have recurrent BV. So is that something we can just like move forward with, but maybe gathering some of that information to make it easier for kind of the next steps of treatment and helping the patient feel better. Um, right, again, rendering treatment for gonorrhea. You all are oftentimes the first line for results, sharing that with patients, figuring out do they want to do pill or like a suppository, and then oftentimes you all are sending us treatment orders for cosign, and then providing education as you already have, and as I've like kind of outlined above, ways to avoid BV, ways to avoid yeast, how to kind of improve their outcomes. And then you all may have other ideas about how we can work together to take care of our patients. And so, in summary, which you can share in the question section, which is coming very shortly, in summary, consider universal testing for STIs in sexually active individuals at least once a year, especially in those folks less than or equal to 25. Some people are like, my partner would never, and their partner has. If possible, test every time a patient has symptoms and avoid empiric treatment alone without testing prior to treatment to confirm the diagnosis. So it may be that somebody comes in and says, they are having a fishy odor or they're having like a sour odor and we may test and then treat empirically right then, but at least we have the results. And so if it's negative, one, we can say stop using metronidazole because it's not always the most enjoyable treatment, but also antibiotics are not without risk. And then incorporate vaginitis testing for those with symptoms concerning for concurrent BV and yeast infections. So if somebody comes in and you're like, yeah, you may have had an exposure that's gonorrhea, chlamydia related, potentially an STI, potentially considering BV and yeast as well. And then consider standing orders for test of reinfection every and or every 3 to 6 months for those participating in high sexual risk practices because it helps make the care more accessible. We talked about how accessibility can be an issue. And if I tell one of my young patients, like, hey, I see that you want to come get testing every 6 months. Like, you don't necessarily have to see me every 6 months for that. Would you like testing to just be in the lab? And so I think, nursing and, even the MAs can help facilitate that. Oh, this person thinks like it would be really helpful to just have orders in the system. And then if they're positive, we can bring them in. But if they're negative, then they know their status and it helps them to have like healthier sexual practices. And then providing anticipatory guidance and education on safe sexual practices. So condoms every time. There are condoms that go on the are external and go on the penis. There are also condoms that sit in the vagina. Shouldn't use them together, but knowing that there are two different types can kind of give people agency and power over, whether a condom is used during sexual activity. Also about STIs, how they're, transmitted or contracted, and that anytime, any type of sex can, even using fingers, making sure that we're educating our patients around washing their toys, so dildos or vibrators, making sure if they're in same-sex partnerships or in multi-partner, dynamic, polyamorous potential relationships, that everybody has their own stuff and they're washing it with soap and water and using silicone. So things like that. It's like higher level than this talk. And then just ways to avoid vaginitis, which we talked a little bit about. So like, clothing changes and cotton underwear and avoiding unnecessary additives to the vulva. And I already said condoms, but making them available and easily accessible is also helps them to be used more often. So my young people, if I give them, they usually have them because they're weird about going to buy them from the store. And sometimes that goes away, but the more we can make it accessible, the better. And now I'm gonna have any questions. But before we end, I'm gonna say the thing I'm supposed to say. I guess I can say it at the end. So if anyone has any questions, please feel free to ask them. I may stop sharing for the time being, and then I'll like reshare my last slide when questions are complete. I'll see what was said in the chat. Yes, good. I'm glad that that was asked. Not questions for me now.
I have a question, Dr. Long.
Okay.
One of the things we did lift was the alcohol restriction for metronidazole and Tendamax or tenidazole. And
Hmm.
it does, you're right, can make them feel crummy, but I don't necessarily know that we have to, they have to be counseled now. It's not recommended that they have to be counseled to avoid now.
Oh, okay. That's, I'm glad that we clarified that. Yeah, I just tell people just not to drink. And then oftentimes I'll have patients who are like, ooh, well, I'm going out for this weekend. I'm like, girl, just go out for the weekend and then do your treatment afterwards.
Or they could do
Just because,
Metrogel. Do you tell them to do
yeah,
Metro?
that's true. Yeah. But I think they're also going to have like sexual fun times at the same time.
Okay.
So, the combination of the two. But yeah. So we shouldn't be saying that, or we should be saying that.
Well, you can tell them it may make them, it may have some side effects where they don't feel so good, but it's not actually a
Mm.
restriction anymore.
Oh, okay. I see what you mean. Yeah.
Mhm.
Okay. That makes sense.
I have a question. I'm just curious why you emphasize testing for reinfection versus like test to cure. Is it like an insurance thing or what?
No, it's actually, I think back, I think oftentimes we think of it like, oh, we're making sure that they were cured. But I think what we've seen is studies show that you treat with the medicine, the infection goes away. It's just that those individuals are oftentimes still having sex with the same partners, and the partners are either are testing or sorry, are treating themselves inadequately or not treating themselves at all. So this new infection that you might see in 12 weeks is not necessarily that they failed the treatment. They took the medicine, the infection was cleared, but they were still having sex with the same partner or a partner within the same community that potentially has been with that partner or another partner and has the infection. And so for gonorrhea, it's not gonorrhea, for yeah, gonorrhea, chlamydia, trichomonas of the vagina that comes back positive, we feel confident that our treatment. Now, there are sometimes when maybe it is recurrent or they have a resistant strain or something like that. But that's pretty rare. So it should really be that we're testing to make sure they're not reinfected again. And only if we're doing pharyngeal testing are we doing like making sure it's actually cured.
No, okay, that makes sense.
Yeah.
Thanks for clearing that up for me.
Yeah, I think the language we used to use was test of cure. But it's not, that's not really what we're doing. We're really just making sure that are they still having sex with the same person? Are they still positive? Did the partner get treated? Like to be able to provide the education, like we need to talk to this person, like we need to actually treat them or you're not going to be better.
Got it. Okay, perfect. And I just found out today that medical assistants are able to administer Procephin. So that's
Nice.
good that they can be more integrated in the care of your patient.
Yeah, that's awesome.
I've been wondering when people message in and say, like, I've been exposed to a partner that's tested positive for, whichever STI, and we give them kind of a range of like 2 to 4 weeks. Like, is there differences in different STIs and how long they should wait so we don't get any false negatives?
Hmm. I mean, oftentimes, if somebody like says in my practice, and in Dr. Christmas, you can also weigh in on this if you'd like to. Say, for instance, like I've had a patient, she knows that her partner was gonorrhea positive. She knows she had sex with that person. We can treat them and test them. It may be negative, but you're going to do the 12-week testing anyways. So I don't know that people have to wait to test or treat if they know they've had an exposure. Now, there are times when somebody like I had a patient who was their partner was chlamydia positive and they were negative, and I still said do the treatment because it likely might be that there is some lag between you having been exposed, have the infection, it's just not showing positive yet. And then if they want, again, you can repeat the testing in some period later, to make sure that they're not, we didn't miss the window, or the partner didn't get fully treated and then they started having sex again and are later positive.
Okay, thank you.
All right. Well, if no one else has any other questions, I'm just gonna, no, that's not the one I'm gonna do. I'm gonna bring up our last slide, so we can conclude. All right, so this is all the time we have. Thank you for joining us for evening round session number 1. We hope the information was valuable and applicable to your work in the clinic and beyond. Please mark your calendars for our next evening rounds, which will be held on July 21st, 2025. This topic will be recurrent pregnancy loss and cerclage placement by not only sorry, by Dr. Laura Douglas. I was going to try to give her like a grand entrance. But we look forward to the next session, and thanks for everybody coming. Hope it was helpful.
Thank
Thank you,
you.
Dr.
You're welcome.
Thank you. Excellent.
No problem. Thanks, everyone.